Hello and welcome to the presentation on Tetralogy of Fallot presented by Ellie, Forbes, LEVIN, and SAGAR, JINDAL. Tom is a 3-month-old infant who has been brought into the Swinburne Hospital emergency department by his parents. Tom's parents are concerned as he has been crying, not feeding properly, and his lips and skin have taken on a blue tint. He breastfeeds every 4 hours, but sometimes takes extended periods to latch and will tire quickly during the feeds. The parents also reported that he was a small baby at birth, but no problems with the pregnancy were detected otherwise. Since birth, Tom has struggled to gain weight and is just under the 15th percentile upon his last check. Upon a primary assessment and vitals check, Tom has a patent airway, a rest rate of 68 breaths per minute, an SpO2 of 90%, and has a visible increased work of breathing, use of intercostal muscles, and head bob. He has a blood pressure of 79/52 and a heart rate of 165 beats per minute. He has a blue tint to his pallor and has a sluggish capillary refill. Tom is also unable to hold concentration to commands and presents confused. Warm oxygen via nasal prongs at either half a litre or 1 litre, depending on Tom's tolerance, has been nurse initiated in order to help improve his SpO2 sats. Recommendations for Tom to conduct an ECG to gain a full picture of the function of his heart, blood tests of hematocrit, platelet count, coagulations, prothrombin time, and a standard blood panel should also be done and are recommended. We will continue to monitor and provide comfort until the results are back and give a clear indication of the medical issue.
Epidemiology of Tetralogy of Fallot. Tetralogy of Fallot is the most common cyanotic heart condition in children who have survived untreated beyond their neonatal age, with the need for an intervention in the first year of life. It accounts for 7 to 10% of congenital heart defects, affecting male and females equally and occurring in 3 to 5 of every 10,000 live births. Pathophysiology of Tetralogy of Fallot. Tetralogy of Fallot is a congenital heart defect which changes the way blood flows through the heart and to the lungs. This condition includes 4 main abnormalities. Ventricular septal defect. It is a hole in the wall that separates the 2 pumping chambers, that is, ventricles of the heart. This hole allows deoxygenated blood in the right ventricle to mix with the oxygenated blood from the left ventricle, which usually results in less blood flow to the lungs. An overriding aorta, the artery that carries oxygenated blood to the body, which is aorta, usually arises from the left ventricle, but in Tetralogy of Fallot, the aorta sits on top of the ventricular septal defect, so it comes off the left ventricle and part of the right ventricle. Pulmonary stenosis is where there is a narrowing or thickening of the valve that connects the right ventricle to the pulmonary artery. The narrow pathway from the right ventricle to the lungs means it is easier for deoxygenated blood to go back around the body. As a result, blood gets to the lungs and lips, tongue, skin, or nails may appear blue, which is cyanosis. Right ventricular hypertrophy is thickening of the muscular wall of the right ventricle. The narrowing of the pathway from right ventricle to the lungs and thickening of the pulmonary valve causes more pressure against the right ventricular to pump. And the heart is a muscle and it has to work harder, and therefore it can become thicker. In Tetralogy of Fallot, the deoxygenated blood returning to the right ventricle passes through the ventricular septal defect to the left ventricle, bypassing the lungs, or may enter the pulmonary artery. Rather than originating from the left ventricle, the aorta overrides both the ventricles. The ventricular septal defect lies in the outflow tract of the right ventricle and is large enough to permit an equal left and right ventricular pressure. This causes a severe obstruction of right ventricular outflow, which produces a right to left shunt, causing decreased systemic arterial saturation, cyanosis, reduced pulmonary blood flow. This develops right ventricular hypertrophy in response to extra force to push the blood into the pulmonary artery. Therefore, pulmonary stenosis is caused in a left to right shunt or no shunt at all.
Implications on childhood development. Implications on tetralogy of Fallot during infancy can directly impact a child's development and future health. Due to the poor oxygenated blood circulation directly caused by TOF, extended cyanosis can cause growth defects and stunt a child's development. This can include a child's muscle, bone, brain, nerve, and cell developments as well. We have 3 goals outlisted below, but we'll go into detail right now.
In the 2020 Ma et al. Article, the writers outline a theory in which school-aged children who had Tetralogy of Fallot, or TOF, at birth had it then repaired, and then they also compared them to healthier children to see if there were any brain injuries or abnormalities between the two groups. They concluded that while the TOF defects were repaired, the lasting implications made them more susceptible to cognitive deficits. The TOF group showed lower verbal intelligence and had a reduced cortical thickness on multiple areas of their brains. They concluded that the results implied that brain damage before the correction of the intracardiac deformity continuously influenced the cortical development and cognitive abilities of the children with TOF. This is further supported by the article by Melazzini in 2022, where their study concluded that patients with tetralogy of Fallot as children showed specific signs of brain injury in adolescence and adulthood and were a higher risk of cognitive deterioration. A way to combat this is for Tom and his parents to find a neurologist for neurological therapy. In the article by Korapati Zailu et al. In 2022, they championed the benefits of neurological therapy for children with tetralogy of Fallot by creating a tailored patient intervention and putting this into place as early as possible, and therefore providing the establishment of prevention and early intervention. Essentially, their research found that early intervention and a tailor-made program to support aspects of neurodevelopment, such as cognition, speech language, and adaptive function, could improve neurological development. Having Tom go through some brain training, particularly through his early life, can try to compensate for the verbal intelligence deficits or other deficits that may occur neurologically that can be caused by the result of tetralogy of Fallot. Linking this into family-centered care, Tom's family can also get involved and continue the training at home and complete the tasks together. In the article by Lee et al. In 2021, they investigated the growth deficiency in pediatric patients with tetralogy of Fallot. They found that the average body height, weight, and BMI of TOF patients compared to the WHO child growth standards, as seen on this slide, was significantly lower. Essentially, they concluded that, similar to the neurological deficit situation as mentioned earlier, early intervention was the best method to reduce the severity of growth deficits. In the article by Costello in 2014, they reported that 51% of their patients in the study they conducted had a feeding difficulty and that this caused a direct relationship between it and lower growth parameters. This was similar to what Jad Cherla in 2008 wrote, and that this was due to delays in feeding readiness, successful gastric feeding, and oral motor readiness and skills. This is also further supported by Marks in 2019, where they identified that infants with tetralogy of Fallot are at risk of having feeding and swallowing problems, and that speech and language therapy can also help with the feeding and swallowing issues that they may encounter. A goal then for Tom and his parents can be to research with the nursing team and with his healthcare team as well, and set up sessions with a speech and language therapist to help with his feeding issues that he may have. As we know from this presentation, tetralogy of Fallot can present in different ways for each child, but individualized plans can be made collaboratively with Tom's parents, and that this will be the best course of action in order to assist Tom. The therapist can give them steps to continue at home and possible ways to help him latch or even just have smaller, more frequent feeds throughout the day instead of larger ones, as an example. Having the parents involved keeps this as a family-centered goal and not just one for the therapist and the health team to focus on. Due to the fact that Tom will be placed in a high acuity setting while his TOF is to be managed and then later repaired, it may be difficult to continue with skin-to-skin contact and normal attachment bonding that would happen with a 3-month-old child. This could be due to either cords, warming beds, or even just the disease control management and Tom being at a high risk to develop infections or other illnesses. Infections in Tom's case can be especially worrying as it could lead to bacterial endocarditis due to the defects in his heart. Early stages of life and bonding between parents and child are essential to their development in later years. Anything inhibiting this can cause potential interpersonal, attachment, and relationship issues for the child later in life. In their 2017 article, Cholestitis and other authors within the research project promote families with sick children such as Tom that can be helped by this situation by early psychological interventions to alleviate stress and reduce the child's emotional and behavioral problems. Essentially, what they concluded is that the aim was to improve coping and enhancing parenting for both the child and parents respectively. This is further supported by Kim et al. In 2020, where their article, they indicate that infants who were hospitalized in the NICU showed a 6.1 times higher prevalence of disorganized attachments by the age of 3. A goal for Tom and his parents to reduce this issue is to continue as much skin-to-skin, breastfeeding, and eye contact as possible, as these are essential to parent-infant bonding. However, an extra goal for them could either be to attain or even join another trial of the device called Hugsy, created by Callis et al. In 2017. Essentially, the Hugsy was a solution that was designed to provide comfort to babies by creating a care situation that simulates parental contact. It was originally made for premature babies, but the same principle can apply to hospitalized infants who may not be able to bond fully due to logistical issues. The Hugsy provides skin-to-skin contact, swaddling, facilitated tucking, audible heartbeat, and aromatherapy. The audible heartbeat is taken from a recording of the parent's heartbeat and aromatherapy of the parent's scent to stimulate that it is actually the parent. They reported that several mothers felt less sad to leave their baby behind and that there were actually positive influences with the child as well while they were in hospital. Lessening the stress on parents and child and providing comfort to the child as well is a positive influence. While still in its early stages, the device, which can be seen on the screen, is a positive step towards reducing the attachment issues sick infants can develop.
How a nurse can promote family-centered care. According to Cocorales et al. In 2019, there are 4 key components to family-centered care. First, collaboration between family members and healthcare providers. Second, consideration of family contexts. Third, policies and procedures. And fourth, patient, family, and healthcare professional education. Throughout this presentation, we have used implementing relevant frameworks such as Calgary Family Assessment, as outlined by Zemansky et al. In 2021. It's also important to remind the family that Tom could even go on to have a full and healthy life with no deficits. For example, Shaun White, a 5-time snowboard Olympian, had Tetralogy of Fallot at birth and after surgical repairs went on to have a normal life, as outlined in the interview with Children's HeartLink in 2022. Each case is completely different. How a nurse can promote family-centered care was touched on in the 3 goals that were set out just beforehand and will be touched again on later on with nursing considerations.
Considerations in care in pediatric cardiology should be individualized for Thomas. These should be representative of his needs and provide him with comfort, safety, and high-quality care, as well as reassure any doubts that Thomas's family may have. Children hospitalized with congenital heart diseases require specific considerations to monitor and maintain cardiac function, tissue oxygenation, oxygen consumption, and fluid and sodium accumulation. The execution of care for infants with cardiac conditions, including TOF, involves satisfactory nursing care and considerations from admission to the neonatal intensive care unit. A component of a child's nursing consideration is extending support to a patient's family, following the patient-centered care approach and continuing with a systematic and appropriate implementation of the fundamental of care framework. Clinicians working with Thomas need to understand the importance of family satisfaction in a patient's recovery, especially those at the developmental stage similar to Thomas. Mother-infant interaction or lack of during the neonatal development stages have been linked to emotional and cognitive development in the infants, which has long-term health consequences. A guardian can facilitate the physical closeness, which includes contact comfort, from skin-to-skin contact to being present in the unit but not in physical contact with the child, or emotional closeness, which describes emotions of attachment, affection, or disconnection. Physical and emotional closeness usually complement each other. However, in stressful situations such as hospital admissions, parents can be physically or emotionally detached or unable to be physically close to their child due to hospital policies. Nurses and clinicians need to understand the deleterious effects that separation can have between an infant and their guardian and do the best to facilitate this. Many theorists have created frameworks that revolve around family dynamics, such as the Calgary Family Assessment Model, as mentioned earlier, which would be essential for the interdisciplinary team to implement. There have also been various studies that have outlined the importance of educational inclusion with a patient's family, specifically for a patient as young as Thomas. A study conducted by a researcher discovered that parents of pediatric patients who underwent corrective surgery for chronic heart disease often, quote, experienced negative emotional reactions and required ongoing home care support, end quote. This study highlights that the psychological pressure experienced by parents, such as the parents of Thomas, as negative emotions were reported to be significantly higher than illnesses caused by chronic diseases. This research should be considered while treating Thomas, with clinicians striving to include explaining each process and action with the family. Due to the nature of Thomas's heart condition, he will undergo surgical intervention, which will inevitably induce feelings of fear and concern for both patients and their support network. This situation may also require changes in home life states and regions, which can impact things such as daily routines and employment. It is essential to acknowledge that these potential situations are likely to occur and should be considered while caring for Thomas. Creating an action plan that emphasizes emotions is an effective strategy for reducing anxiety and stress prior to Thomas's discharge.
Here's a list of references used throughout this presentation. Thank you for watching.